You know, you might look at a child missing their three middle fingers and think the surgical priority is obvious. Like you just close the massive gap right in the center of their hand.
Right, which makes sense visually, but
But you would be completely wrong because in the board exams and, well, more importantly, in the operating room, we actually don't base our primary reconstructive strategy on the missing central fingers at all.
no, we don't. We base it entirely on the thumb.
Exactly. And look, you are a plastic surgery resident, probably running on caffeine and pure adrenaline right now, just staring down the barrel of the FRCS exams.
Yep.
You need high-yield functional mechanics, not, rote memorization.
Yeah, that is the exact mindset you need for this. I mean, this is really about synthesizing the clinical picture so that when you are presented with a clinical photo or a written vignette, you just immediately understand the underlying anatomical logic.
And the reconstructive threshold, right? So today's revision session is a deep dive specifically engineered for mastering central hand deficiencies.
Yeah.
No suff, no wasted time, just the critical differentiators, the biomechanics, and the surgical management strategies that examiners absolutely love to test.
It's all high yield from here on out.
Yep. But real quick, before we jump into the surgical pathways, do yourself a massive favor. Press follow on whatever app you're using right now so you don't miss our future revision sessions.
Definitely do that.
And hey, if you learned something valuable today that helps you score a point on the boards, leave us a rating. Also, if you're actively prepping for the fellowship exams, grab a premium subscription. That is strictly where we house the Journal Club and the clinical cases deep dives.
Which are absolute gold mines for testing your application of this theory, by the way.
Exactly. Don't miss out on those. All right, we are doing this fast-paced question and explanation style. So, historically, central hand deficiencies were all lumped together as cleft hand and divided into typical and atypical.
Right, which is quite confusing.
Yeah, because framing it that way implies they're just two ends of the same disease spectrum.
Yeah.
But they aren't, right? They're completely different embryological beasts.
Totally different, yeah. The terminology is definitely a trap for the unwary candidate. When an examiner asks you about a typical cleft hand, you must immediately think of a highly predictable, genetically programmed blueprint.
Okay, break that blueprint down for us. Anatomically, what are we looking at?
Well, anatomically, you are looking at a V-shaped cleft right in the center of the hand. And usually it's the third ray, the middle finger, that is absent. But the real exam points are in the systemic markers.
Right, the stuff outside the hand.
Exactly. A typical cleft hand is often bilateral. It frequently involves both the hands and the feet. And the inheritance pattern is strongly autosomal dominant.
So if you're taking a history in a clinical station, you absolutely must ask about the parents and siblings.
You have to, yes.
So if a patient presents with a central V-shaped cleft, you are immediately looking at their feed, taking a detailed family pedigree, and what about syndromic associations?
Well, you also need to look at their face and skin, because typical cleft hand may form part of a broader syndrome. And the classic one you must memorize for the FRCS is EEC syndrome.
Right, EEC.
Yeah, that stands for ectrodactyly, ectodermal dysplasia, and facial clefts, where ectrodactyly is the structural limb malformation itself.
Got it. Let's zoom back in on the limb malformation for a second. Beyond the missing central digits, what are the specific anatomical markers inside that hand that dictate the pathology? Because, I mean, it is rarely just a clean missing bone.
Oh, it is rarely ever clean. First, you look at the bones lying horizontally across the cleft. These are the transverse metacarpals.
Okay, transverse metacarpals.
Second, the phalanges bordering the cleft might be abnormal, like you will frequently see longitudinally bracketed epiphyses. And third, and this is honestly the most important for function, the first web space between the thumb and index finger is very often narrowed.
Right, and those transverse metacarpals are just fascinating from a biomechanical standpoint. I always picture them as like a biological wedge doorstop.
That's a great way to think about it.
Because if you have a horizontal bone sitting at the base of that V-shaped cleft, it doesn't just sit there inertly. As the child grows, that transverse bone is going to dynamically push the radial and ulnar borders apart with, like, every millimeter of pediatric growth.
Exactly. It actively worsens the deformity over time.
Yeah. And the longitudinally bracketed epiphyses, where the growth plate actually wraps around the side of the bone, they tether the longitudinal growth and force the adjacent fingers to deviate angularly into the cleft.
That is precisely the mechanism of progressive deformity. The anatomy is actively working against the child's hand function as they age.
Which perfectly sets up the rationale for surgical timing.
No.
But before we cut, we really have to classify. Logic might dictate that if the condition is defined by a V-shaped central cleft, we should classify the severity based on the depth or width of that cleft. But we don't do that.
No, we completely ignore the cleft for classification.
It's so counterintuitive.
It is. But for typical cleft hands, the gold standard is the Manska and Helicus classification, and it focuses entirely on that first web space we mentioned earlier.
Which brings us back to the premise of this whole deep dive.
Huh.
We care about the web space because some function dictates hand function.
Exactly.
Like if you don't have a functional first web space, the hand is essentially just a spatial hook. You cannot achieve opposition or a functional pinch grip.
Right. So, Manska and Helicus evaluates the progressive narrowing and eventual obliteration of that first web. Type I is just your baseline, so a normal web.
Okay, type I is normal.
Then type 2 is where the narrowing begins, and it is subdivided. Type IAA is mildly narrowed, meaning there is still some functional space, while type IB is severely narrowed, which significantly restricts thumb abduction.
Okay, so types I and II are simply a spectrum of narrowing. If that web space keeps shrinking, eventually the tissues must fuse, right? So I imagine the next step in severity is a soft tissue fusion. Is type 3 essentially just a complete syndactyly?
Yes, exactly. Type 3 is a syndactylized web. The first web space is completely obliterated by a syndactyly between the thumb and the index finger.
Wow.
So the space exists skeletally, but it is entirely bound by soft tissue.
Okay, so if type 3 obliterates the space with soft tissue, the only logical progression for type 4 is structural loss. Does the index ray itself start to disappear?
That is the defining feature of type 4. We call it a merged web. The index ray is suppressed to the point that the first web space merges entirely with the central cleft.
So the anatomical landmark separating the thumb from the central defect is just gone.
Gone, yes.
And the final stage, type V, must be the catastrophic failure of the entire radial border.
Correct. Type V is an absent web because the thumb elements themselves are suppressed. There is no first web space because the foundational thumb structures simply did not form.
Okay, that progression makes complete mechanical sense. You move from narrowing to soft tissue tethering to index suppression to total thumb absence.
Well,
So it's like grading a donut by the quality of the remaining dough, not the size of the hole.
yeah, exactly like that.
Now, let's translate this into the operating room. There is a classic phrase examiners love to drop regarding typical cleft hands. They say it's a functional triumph, but a social disaster.
Oh, they love that phrase.
Because children with this condition adapt incredibly well and have surprisingly good grip strength, despite the dramatic appearance.
Yeah.
Given that, when do we actually intervene? Like, when do we rush to the OR, and when do we sit on our hands?
Well, timing is everything for the boards here. You only perform early surgery for one specific reason, and that is to prevent the progressive deformities we discussed earlier.
You mean the biological wedge?
Yes, the wedge. You must operate early, often within the first few months of life, to excise those transverse metacarpals, because if you leave them, they physically force the cleft wider.
Are there any other reasons for early surgery?
The only other strict indication for early surgery is to separate syndactyly between unequal digits, such as a thumb index syndactyly in a type 3 Manska and Helicus.
Right, because if you have a longer index finger tethered to a shorter thumb, the longer digit will inevitably bow and deviate as it tries to grow past the physical restraint of the web.
Exactly.
So early surgery is strictly protective. You are not doing the definitive aesthetic reconstruction yet. You are just stopping the anatomy from destroying itself. So when does the definitive closure happen?
The definitive reconstruction is postponed until the child is between 1 and 2 years old.
Okay, 1 to 2 years.
Right. This is the sweet spot where the anatomical structures are large enough to handle safely, but the child hasn't developed ingrained maladaptive motor patterns yet.
What are we actually doing then?
This is when you address the first web space release, close the cleft, and potentially create a thumb if it is a type V absence.
Okay, let's break down the surgical techniques for that 1 to 2 year mark, because FRCS examiners will absolutely ask for named flaps. When you are closing that V cleft and simultaneously trying to deepen a narrowed first web space, what are the primary workhorse methods?
You really need to memorize two distinct approaches. The first is the snow littler technique.
There's no littler.
Yeah, this is functionally a tissue sharing procedure. You take a palmar-based flap of redundant skin from the cleft itself, elevate it, and then transpose it radially into the first web space to provide the missing width.
So you're basically harvesting the excess skin created by the cleft deformity to solve the soft tissue deficit in the thumb web.
That's it, exactly.
It's mathematically elegant. But transposing a palmar flap can be bulky, right?
Yeah.
And it sometimes suffers from marginal necrosis. So what is the alternative?
The alternative is the Miura and Kamada method. This is generally considered a safer, simpler technique in terms of flap perfusion.
How does that one work?
Instead of transposing a specific palmar-based flap across the hand, it relies on creating dorsal and palmar flaps within the cleft, and then dynamically redraping them to close the central gap while simultaneously releasing the web.
Okay, so snow littler for the transposed palmar flap, Miura and Kamada for the local redraping. But skin is only half the battle, right? I mean, to permanently close that central gap, you have to reconstruct the skeletal architecture. You can't just pull the skin together over a massive bony void.
No, definitely not. The key skeletal maneuver here is the transposition of the second metacarpal.
Moving the index finger.
Exactly. You perform an osteotomy on the second metacarpal, the index ray, and transfer it centrally to the base of the third metacarpal, securing it with K-wires. So you are physically moving the index finger over to fill the missing middle finger's slot.
But wait, if you move the index ray to the middle finger position, you are totally disrupting the intrinsic musculature of the hand.
You are.
Specifically, I'm thinking of the adductor pollicis, which originates on the third metacarpal and inserts on the thumb. That muscle is the primary engine for pinch strength. If you are dismantling the third ray and moving the second over, how do you not just destroy thumb mechanics?
And that is the high-yield anatomical nuance they will test you on. The level of your osteotomy dictates the functional outcome. If you transpose that second metacarpal by cutting it at the level of its neck rather than its base, you can preserve the adductor pollicis origin on the remaining base of the third metacarpal.
Ah,
Yeah, you retain that critical anchor point.
so cutting at the neck preserves the base, which preserves the adductor origin. That's a massive functional win. Now, what about the soft tissues deep in the palm? Once you move that bone over, what stops the hand from just splaying open again the second the child tries to grip a heavy object?
Well, you must reconstruct the deep transverse metacarpal ligament. And to do this, you utilize the adjacent A1 pulleys of the index and ring fingers.
A1 pulley.
Yes, you literally incise them, unfold them towards the midline, and suture them together to bridge the gap.
Wow, see, I always found that maneuver slightly counterintuitive, because an A1 pulley is just a retinacular sheath. How does unfolding a thin sheath provide enough tensile strength to hold two metacarpals together against the outward force of a power grip?
Well, initially, it just provides a structural scaffold. But over time, the body's fibrotic response to that sutured connection essentially scars it into a robust ligamentous band. It mimics the missing transverse ligament well enough to prevent splaying.
That is fascinating biological adaptation.
Okay.
Okay, now, before we leave the typical cleft hand, let's address type V, the absent thumb. If the thumb elements are completely suppressed, what is our reconstructive pathway at that 1 to 2 year mark?
If the thumb is absent, your primary option is pollicization of another digit, usually the index finger if it is viable.
But what if it isn't?
Right. If there is no available radial ray to pollicize, you have to look outside the hand entirely. You are looking at a free toe transfer.
Which brings us back to the feet, because we established early on that typical cleft hands frequently involve bilateral cleft feet. If we need toes for the hand, or if the foot clefts are severe, when do we operate on the lower extremity?
Almost never for cosmetic reasons. The functional demands of the foot are entirely different from the hand. The foot is a rigid lever for weight bearing and gait. You only operate on foot clefts when the splaying is so severe that the patient has difficulties fitting into standard footwear.
So if a free toe transfer is required for a type V typical hand, but the feet are also clefted, how do you select your donor site without destroying their gait?
You have to respect the biomechanics of walking. The fibular rays of the foot, so the lateral side, are the most critical for weight bearing and normal push-off during gait.
So you leave those alone.
Therefore, you do not mess with them exactly. The tubular toes, specifically the second toe, can usually be safely transferred to the hand without causing significant donor site morbidity, even in a cleft foot.
Okay, let's transition. If typical clefts are these highly predictable, genetically programmed blueprints where we know exactly how the web space will behave, What happens when the limb bud development just spontaneously stutters and fails?
That brings us to what used to be called the atypical cleft hand.
Right, and the first thing you need to do for the exam is strike atypical cleft hand from your vocabulary, isn't it?
Mm.
The modern, correct terminology is symbricadactyly.
Yes, symbricadactyly.
How does the clinical phenotype of symbricadactyly contrast with the V-shaped typical cleft?
Well, it is practically the inverse presentation. Instead of a V cleft, symbricadactyly is characterized by short vestigial digits. You will see small soft tissue nubbins, frequently with tiny vestigial nails attached to them, just sitting where fingers should be.
And what about the systemic profile? Like, if typical is bilateral and inherited, what is symbricadactyly?
Complete opposite. Symbricadactyly is overwhelmingly a sporadic unilateral event. It seldom involves the feet, and it is not associated with a familial inheritance pattern.
Okay, so for everyone listening and trying to memorize this while commuting, the key differentiator here isn't just the shape of the hand, it's the chest wall.
Yeah.
What is the classic syndromic association we must look for here?
Symbricadactyly frequently occurs with Poland syndrome.
Right, Poland's.
If you see unilateral short, webbed, or missing fingers with vestigial nubbins, you must mentally check the chest. You are looking for the hypoplasia or complete absence of the sternocostal head of the pectoralis major muscle.
That is a classic spot diagnosis combination. Now, earlier we talked about typical clefts being true central ray deficiencies. Where does symbricadactyly fit into the Swanson classification of congenital limb differences?
This is a major area of controversy. Its place within Swanson's classification as a failure of formation is highly debated.
Oh, really?
Yeah, most modern experts agree that symbricadactyly is probably not a true longitudinal central ray deficiency.
Meaning it's not a genetic failure of the longitudinal axis like a typical cleft, but rather a catastrophic vascular event, like a localized subclavian artery supply disruption during embryonic development that just halts growth across a transverse plane.
Exactly. It behaves embryologically and morphologically like a completely different condition, driven by vascular disruption rather than a faulty genetic blueprint.
Which means we need a completely different way to classify it. We cannot use Manska and Helicus because that evaluates the progressive failure of the first web space. So what is the preferred framework for symbricadactyly?
We use the Blouth and Geckler classification.
Blouth and Geckler.
Yes. Instead of web spaces, it divides the condition into 4 distinct types based on the distal to proximal severity of the absent structures.
Okay, let's group these by functional reconstructive thresholds. What is the baseline?
Type 1 is the short finger type. Here, the patient has a thumb and 4 short, stiff digits.
And how functional is that?
From a reconstructive standpoint, their function is usually excellent. They might require a simple syndactyly release if those short fingers are webbed together, or occasionally a free phalangeal bone transfer from a toe to give it a bit more length to a specific digit, but they are highly functional as is.
So type 1 is usable. What happens when we cross the threshold into structural loss?
That brings us to type 2, the oligodactylic type. This is what used to be mislabeled as the classic atypical cleft. It presents with central aplasia.
Okay, so what does that look like?
The patient has a thumb and a little finger, but the central digits are reduced to severe nubbins.
So you have border digits but no center. How do you surgically salvage a hand with just 2 parallel posts on the edges?
The reconstructive goal is to build a functional pincer grip between that thumb and the little finger. To achieve this, we perform metacarpal rotation osteotomies.
Wait, we are literally breaking the metacarpal bones at the base of the thumb and the little finger, twisting them so their palmar pads face each other and pinning them.
Precisely. You are turning 2 useless parallel posts into a functional clamp.
Wow.
Yeah, you vastly improve the mechanical advantage of whatever digits they have left.
Which leads us to type 3, the monodactylic type. As the name implies, there is only one functional digit, usually a thumb, alongside 4 vestigial nubbins.
Right.
If we only have a thumb, can we build them fingers using toe transfers?
This is where we hit a critical surgical threshold. Some oligodactylic and monodactylic patients are suitable candidates for toe-to-hand transfers. But, and this is a big but, you can only perform a free toe transfer if the underlying metacarpals and the extrinsic flexor and extensor tendons are actually present in the palm to hook the new toe up to.
Oh, right, like trying to install a light fixture where there's no electrical wiring in the wall.
It's exactly.
If there is no proximal engine to pull the tendons, transferring the toe is structurally useless.
Yeah.
But if they do have the tendons, we pull from the feet, which brings up an incredible anatomical irony. We use toes for symbricadactyly reconstruction, But we explicitly stated earlier that symbricadactyly is unilateral and seldom involves the feet.
Exactly. It's ironic. Unlike the typical cleft hand patient who often has complex bilateral cleft feet to navigate, the symbricadactyly patient's feet are essentially pristine donor sites.
Wow.
It is a perfect anatomical coincidence that allows for extensive microvascular toe transfers, provided the proximal hand anatomy permits.
And what if the proximal anatomy does not permit? What is the final Blouth and Geckler type?
The paramelic type. This is the most severe manifestation. It is the complete absence of all fingers and the thumb.
Complete transverse arrest.
Yeah.
So what are our surgical options for paramelic hands?
Microvascular reconstruction is generally impossible because there is a total lack of proximal structures, no metacarpals, no functional extrinsic tendons. You just cannot transfer a toe. The foundational anatomy just isn't there.
So what do you do?
These patients are usually managed with prosthetics rather than surgical reconstruction.
Wow. Okay, well, we have covered an incredible amount of ground today. Let's do a rapid-fire wrap-up.
Okay.
If you want guaranteed point scores for the FRCS exams, you must master the dichotomy between these two distinct pathologies.
Right.
On one side, you have the typical cleft hand. V-shaped, inherited autosomal dominant, bilateral, and frequently involves the feet. It is deeply associated with EEC syndrome. We classify it using Manska and Alikis, which focuses entirely on the viability of the first web space.
Spot on.
Surgical time is delayed to 1 to 2 years for Snow-Littler or Murakamata reconstructions, unless progressive deformity from transverse metacarpals demands early protective intervention. Then on the other side, you have symbricadactyly. These are your vestigial nubbins, unilateral, sporadic, with pristine feet, highly associated with Poland syndrome and an absent pectoralis major.
Perfect.
We classify it using Blouth and Geckler based on the functional threshold of the remaining digits, utilizing rotation osteotomies or toe transfers only when the proximal tendinous engine is present.
Recognizing which of those two distinct pathways you are on the moment you look at the clinical photo is the absolute key to unlocking the right classification and the right treatment algorithm on exam day.
Absolutely. So before you get back to your flashcards, drop down into the app and leave us a comment or a question about this topic wherever you are listening. We want to know what specific areas of hand surgery are tripping you up in your revision.
We'd love to hear from you.
And we want to leave you with a final puzzle to ponder on your own. Just something to chew on while you're reviewing your anatomy notes tonight. We noted that Swanson's classification's inclusion of symbricadactyly is controversial because it behaves like a transverse vascular disruption rather than a genetic failure of the longitudinal axis.
Right.
If that is true, how does that totally reframe our understanding of the embryonic accidents that cause it compared to the rigid, inherited genetic blueprints of a true, typical cleft hand? Think about that vascular disruption versus genetic programming. Good luck with your revision, and we will see you on the next deep dive.